Welcome back to another episode of the Brawn Body Health and Fitness Podcast. Joining me for a second time on the show today is Dr. Tim Stone. Tim is the COO and a physical therapist at True Sports Physical Therapy. You can find them throughout Delaware, Maryland, and South Central Pennsylvania. Tim and I are going to be discussing practical programming considerations for your patients after ACL surgery. So things like supersets, quad loading, how much quad loading, how often should you load the quad, how you should address your home exercise program, and so many more important things that a lot of people just don't really think about. So, great episode, a lot of great content and information in it. For more information and insight on how to rehab someone after ACL surgery, I highly recommend that you check out the True Sports course that goes over all of this. We have a link to the description in that below. Tim and his team did a great job putting that together, and there's so much great information that can help you in rehabbing someone after ACL surgery. Enjoy. Tim, welcome back to the podcast. Super excited to work with you again today, man. Thanks for being here.
Dan, thanks for having me. Appreciate what you do. Second time now, I'm happy to be back.
Yeah, and not to mention, the first time you were the second most downloaded podcast we had this year. So you beat the Starrettes, you beat a lot of awesome people. So you're certainly someone that I think has a lot of impact and influence in the physical therapy space. And you certainly have a great wealth of knowledge as it relates to the ACL. I've had the pleasure of knowing you for quite a while, but for people who maybe don't know you as well, would you mind filling them in a little bit about who you are and all the amazing things you do?
Well, first off, I don't know if I could take credit for all those views. I think probably like having a world-renowned surgeon like sitting beside me is probably the reason that that pod did so well. But I'll take the credit. So yeah, I mean, I've been a PT for coming up 7 years, mostly in Maryland, but I grew up in Perth, Western Australia, and that sort of started my journey. I started physio school there, but had the opportunity to come over and play lacrosse in college here. So dropped everything, came here and did that. And then, I just loved being around sports PT and loved going through the athletic training room as an athlete. Loved the industry and just saw how, unique it was in the US and how much access you had to people who are really competitive athletes. And I think that's really different here in comparison to most other countries. So, that was a big factor in choosing sort of to go to PT school here and do that. And then also, of course, as it goes, you go to undergrad and, fall in love. And that was another big piece of me staying here and, starting a family and all that kind of stuff. So, I did my PT school at University of Maryland. Moved down to Florida for a brief little stint, and then was really fortunate enough while I was in PT school to work with Yoni Rosenblatt, owner of True Sports Physical Therapy, and he sort of gave me my first real chance in the sports PT world. So he brought me back up from Florida, and we sort of just set the goal to the target of just expanding that one-on-one 45-minute care for our high school, collegiate. A little bit of pro stuff, and then the avid fitness adult around the Maryland area, and have been really fortunate enough to grow that now to 13 practices. Maryland, we have a little bit in Delaware, a little bit in Pennsylvania too. So I'm still basically like a one job or one job career person, and I've been really fortunate to be able to do something I love from the get-go and sort of have a great mentor and learn all the skills and have the opportunity to grow a niche and become, I guess, a little voice in the world of ACL stuff now. So that's kind of my journey so far.
Yeah, definitely. And as you mentioned, you've certainly kind of become well known in the field of ACL rehab. I think you have a Con Ed course about it now even. And that's sort of where my mind goes when I hear the name Tim Stone, is right to the ACL. And that's our whole first podcast we did together last time was all about the ACL. And if you didn't listened to that yet, I highly recommend you do. Just to kind of recap real quick, if someone's listening and maybe they aren't familiar with typical ACL tear, ACL injury, that sort of thing, would you mind kind of giving them a quick rundown of what happens and how it's injured and the general kind of stuff we look to do from a physical therapy standpoint?
Yeah, so there's a multitude in ways in which you can, tear your ACL. The most common way that we see is that non-contact ACL tear, where you have, someone pivot or plant, and then there's this like valgus, hip internal rotation stress, maybe some hyperextension or extension piece in there as well. And basically, the ligament like is not able to handle that, and and also there's usually a little bit of like lateral flexion that goes on in the trunk as well, which is a big contributor. And then basically you are, the result is an ACL tear. So that's kind of like the most common mechanism. Obviously, like there are some other ones that are a little less common. Next being, some sort of contact injury where you get like a forceful blow to the knee through hyperextension or that valgus or hip internal rotation piece. And then obviously like the catastrophic, more like collision based things, car accidents, falls, like that kind of stuff. So, it's mostly, what we're dealing with in our niche, and what we're seeing for the most part in terms of like where the field is most interested in is in that non-contact tab, just because of the high volume of them. And I guess as a profession, we feel like that's something that we maybe can have more control over preventing in the future. And so that's, where most of the dollars and cents are spent in trying to like see what we can see how we can have an effect on reducing the incidence, occurrence of ACL tears.
Right. So there's certainly a focus on prevention, but sometimes some of these injuries, as you mentioned, are unfortunately unavoidable and are probably going to happen regardless. There's certain hits I look at, watching football, for example, and it's like, if I took a hit like that, my knee's probably going to get blown up. So some things we can certainly prevent, hopefully, but I certainly think there's an element of tears that are unpreventable. And when they do end up tearing, I think it becomes really important from a rehab standpoint that we really give everything we have to the person in front of us, because there's a subset of people who tear their ACL, get surgery, and then they don't get back to where they were before. And that's kind of concerning from my standpoint. And I feel like there's probably ways that we as PTs and providers could do better for them.
Yeah, I think the profession's come a long way in terms of like the guidelines of how to treat this injury, and how to be successful in terms of like returning people to health. I think if you would ask, 10 years ago, just getting people back to like normal daily metrics was a challenge. I think we've kind of gotten through, majority of that part, but the numbers in terms of like return to prior level of competition, it's not good, and it's pretty staggering. And I think I don't think as a profession we have like spent enough time looking at that being the metric for success, right? We look at not re-tearing as the metric for a surgical success for ACL reconstruction, and that just doesn't exclude all the people that get a reconstruction and never go back and challenge the knee again to the way in which they were doing it before. And so, that's the future, is making sure that we're able to, really consistently and successfully and effectively return people back to what they were doing prior, or what they were doing whilst they, had the ACL injury. So, I think that's next.
Definitely. I think effective programming for the athlete in front of you is a real big key contributor to that. I think a lot of the athletes that I've seen over the past year and a half who have been struggling or having issues with, that return to sport or return to high level competitive function, somewhere along the line, something was missed in their programming, whether that's using straight leg raises for quad strengthening 4 to 5 months post-op, or being at the return to sport level, but only having 65% quad symmetry. There's been a lot of instances where I kind of see something and I just feel like somewhere along the lines we missed something from like a strengthening and programming standpoint for the person in front of us. Is that something that you typically see from, patients that go to clinics that aren't your own that way? Or
I think we see this a lot amongst like people that come through True Sports. I think I'm fortunate a little bit more now to have like developed, I guess, a referral basis where I'm like really fortunate enough to probably like see majority of my ACLs from day one, or even prior to surgery. So like I don't typically deal as much with like getting someone that's not been successful at another clinic with my hands, but under my care. But our PTs certainly do that every day, and there's a good, when we see a person that comes in for an eval and they have a surgical date that's like 3 weeks prior to when they come here, there's always that like, oh crap moment. Like, what are they going to be missing? And why are they coming to us now? And what are we going to have to do to like, figure out like how we make up for that lost time? So yeah, I think you hit the nail ahead in terms of like the programming. I think also, I guess I would say just from a more broader sense of things, like planning of like how you're going to manage this from day one all the way through to 9 to 12 months. And I think having a good guide and having a good plan for what it looks like is really where I just don't think we have a great consensus yet as a profession. And I think that lacking that consistency or lacking that voice in terms of like at least a really solid approach to it is where we're falling short, right? Like I just don't, there shouldn't be people that come into your clinic that don't hit their range of motion goals in 3 or 4 weeks. Like that just shouldn't be a problem. But when I'm looking around like online or wherever you get your information on, it's not really like, hasn't been really adopted as like a yes, you have to have XYZ by this time frame. We're not solid enough on that stuff. And then even if we are solid with some of the information that's out there, we don't really do a good job of teaching people on how to get it. And so, or how to evaluate, are they getting it or doing a good job with it? So yeah, there's like a missing link between, is the information out there good and solid? Is the plan out there good, solid, consistent? And then also like, is there good information out there on how to meet the expectations of that plan? I just don't think we're at that point yet.
Right. I completely agree. And I think this was one of the early things that you had taught me during my time as a student there is, patients have to earn the right to progress, but ultimately you need to know what that progression looks like. You need to know where they're at today. You need to know the next step in line, and you need to know that all the way up to level 50 or 60 from where you are today. And I definitely agreed with your point that there's a lot of people that struggle to kind of grasp that concept. And I think that's where something like just programming more effective sessions for the person in front of you, I think that can really speak volumes and open up a lot of opportunities for that. And what I mean by that is, say you're looking at your return to run criteria for someone and you say, hey, I want them to have 15 single leg squats before we get them back to run, make sure we have a little bit of functional strength. If that's your goal, then you should be able to regress it all the way down to where they are when they're standing in front of you and progress it all the way up to them doing single leg squats for reps.
Yeah, I totally agree. Like there's great information now, and we talk about this in the course, and like these metrics, there's so much data and things like that you can analyze to see, are they ready to return to run, or are they ready to like return to cut? And there's some good studies that show, how to do that. But really like what PT should be is a series of like tests and then like therapies that sort of progressively like assess where you are at on a daily basis and then put that back into what the treatment is. And so we certainly weren't tied around testing. I'm still kind of like new into that world of like using all that data and metrics to guide my therapy. But what I did do really well from an early stage is like make sure I took note of like, if it is return to run, like what's the half stage before return to run, what's the half stage before that, what's the half stage before that, and so that you can sort of like check each box on like a daily basis or like on a weekly basis to know that you are moving in that direction. Now, those things are quasi-objective, and a lot of them sometimes are less than that. They're even a little bit more subjective. But like you said, as long as you plan them out, and as long as you're ticking those boxes, you can definitely move someone through this rehab fairly well. If you're unsure about like, or if you don't have access maybe to like all those data analytic things that a lot of the research that is out there is like based upon.
Yeah, no, definitely, definitely. And you bring up an excellent point there and the importance of the subjective. And I remember you've had this conversation multiple times in the past on the importance of the subjective, especially as it relates to return to sport, return to run, listening to the athlete in front of you, if they're ready, if they're not ready. At the end of the day, that's the ultimate litmus test, because if they tell you they're not ready, they're probably right. But I think that programming effectively can help get them to the point where they feel more ready to go when that time comes. If I want someone to return to run and they've already squatted, 225 for reps day in and day out, and they're just feeling strong and confident and solid, then that day's probably going to go a lot better than someone who's still stuck on the table at 3-4 months.
Yeah, you I think develop through experience a litmus test or an idea based on things like different exercise completion as part of your programming. So, whether that be, like you said, a single leg squat to whatever height box you pick at, whatever weight for reps, like the last person or last 5 people you had in the clinic that were able to do that ran successfully on their first time at this time point. And so like developing some of those things yourself can be really helpful as a guide. Like you said, like if you can squat 225, I think for the most part, that's definitely like a hint at they're going to do better than someone that can't do that, right? But it's not all inclusive at the same time. So, that's how I kind of, I think, developed in terms of like picking things that helped me progress through. I didn't do it from an original like testing perspective. I now see the value of both for sure. But you're totally right. Like if you want someone to be successful at running, like what's the other things that they should be able to do like in front of you that would sort of like possess some of the qualities of running? If you can check that box, you're more likely to be successful with that person running.
Yeah, definitely. Completely agree. And, to this point here, we've talked about the importance of getting them to that point, and we need to progress them back. And I mentioned that we kind of load people a little bit with movements like, say, a weighted squat or a single leg squat. And I think it's pretty important for us to kind of establish that it's safe to load patients after they've had ACL surgery. I know that there's a lot of, uneasiness or unsteadiness about different things like, when should we do the leg extension and different things. But I think ultimately we really need to get strength back, and strength is one of the most important metrics for us to get. And we get that by loading someone, loading them heavy, loading them often. What kind of metrics do you look at yourself when you're programming for your patients? Are you programming like sets to failure every single day? Are you programming like, every other day? Like what goes into your programming considerations for someone in that kind of mid-stage ACL?
Yeah, so I think there's a lot of different ways to skin this cat and look at this. Personally, like I first evaluate how many times I'm going to see them a week, right? And so the program should change based on that. So if you have more contact with somebody, you can divide your sessions up differently. So that's the first thing. So for example, like if you're seeing someone twice a week and you're in that middle stage, and we've already established and know that we need to spend most of our time doing, quad strength stuff, I'm probably reserving like most of both of those days solely working on quad based like exercises or quad based loading on both of those days, and then making sure outside of therapy the patient's sort of hitting everything else. I know that you know hinge work, like anything posterior chain, anything that's like hip related, is probably less less difficult to achieve independently than it is in therapy. And so like I want to work with them on, if I have an hour and a half with them a week, like I want to work with them on the thing that really, really matters first. And so that's what I would do for someone that's coming twice a week. 3 times a week, I'm probably going to do 2 of those are based mostly on quad, and then the other day is on something of everything else. So that gives you like an idea about like the volume at that middle stage and where we're spending our time on a very general basis in terms of like what like muscle groups we're targeting. That's kind of where I hit. So that's like the first thing I would look at in terms of programming. It's just like what you're doing on each day.
Now, does that change based on does that change based on the graph that you have? Because like say you get a hamstring instead of the quad or BTB, does that focus of quad strength versus hamstring strength change at all to you?
Yeah, I think it does. But I think this is where the testing comes in, and this is where like someone I really respect who works with us, our colleague Ray, sort of like opened my eyes to this concept recently, where you can utilize like that information less of whether like you're using what they use to do the surgery, or like what tissue they use to reconstruct the knee, and more of a sense of just what do they need, and he had this great post a couple of months ago that just looked at like basically performing 100 sets a week of training where you would spend your time doing that. And I think this is a really simplistic way to look at like how you would break up your time spent during the week. So let's say I was saying to you basically like I think that at this time point we should spend probably 90% of our time working on quadricep strength, right? And so I go along this path for a month. Well, with a hamstring graft, like that's going to go pretty well, I think, right? Like they're going to recuperate quad function fairly easily compared to a quad tendon graft or a BTB, patella tendon graft. So, how do I know when to switch 90% to 80%? Or like, how do I know to switch 70 of those sets to quad and 30 to everything else? And so, this would be the plug for the testing side of things. Like he posted and sort of like retested somebody, and it was like similar to that. I don't know if it was 80 or 90% quad stuff, but when they tested, they made great strides with quad function, and QI looked really good. And so from that, and hamstrings were the most obvious things that were still lacking. So from that, he just basically like switches up the percentage of sets per week that you're working on the tissue that has the greatest deficit. And so I think that's where the graft choice comes in. I'm not making necessarily like my decision on how many sets I'm doing based on what the injury is, but based on where their deficit is. And so you have to know where that deficit is. If you have no access to really good ways of measuring like quad function or QI or hamstring function or hamstring symmetry, then I would use the basic guideline of like middle stage, you're like 80 to 90% working on single leg quad strength. But if you do have access to some of that, and it's really easy to find that stuff cheaply now, or relatively cheaply now, you should use that information to test all the different major muscle groups and see where their biggest deficit is, and use that to guide you on your, quote unquote, 100 sets a week.
Yeah, I like that. I like that approach, and I like how that kind of breaks it down. And I like the 100% or 100 sets correlation with percentage too. Like,
right.
If I want to spend 80 sets of quad, that's also going to be 80% of my time. So if I get them 90 minutes a week, like you said before, then I can expect to be spending somewhere around 80 minutes of that on quad strength and quad function. And then the rest can just kind of be finishers for something else.
Right. And that sounds like a lot of people listening to this might sound like, well, that's crazy. Like you're going to apply 10% or 20% of your time to all the other muscle groups. It is wild. It is a lot, but I'll tell you this, like the further I got along, like years into this, the further I pushed that percentage along. So I think I knew quads were important. So I would do 50% of the time on that one muscle group and 50% of the time on like everything else, and it wasn't yielding the response that I think I wanted it to over time, whether or not like I was really efficient at hitting the quad when I thought I was. Maybe I need to get better at that. But it might be an exaggeration to say 90%, but it's not far off. Like if you're new to doing this, or if you're in your first year to doing this, like it's not a regular workout. Like you don't need to go like half if you're doing like regular bodybuilding splits. Like you don't need to do like, half chest and then like the other half tries, right? Like it should be in this scenario like 90% chest and like a finisher on tries, right? Like you can exhaust a lot more percentage or a lot more time on just that single leg quad strength than you think. Because if you miss the target, right, like at the 8-month mark and quads are killing it and you're at 100%, well, one, you're better than 95% of the PTs out there. But in a month or 6 weeks or 2 months, the other stuff will come back pretty quickly if you have to go back to it. If you're at 8 months and you're still at 70% quad strength, like you're not getting there in the next month. You know what I mean? Like you're gonna have to spend a lot more time, and that's time that you're certainly not able to do like high velocity movements and cutting because they're so quad dominant. Like if you do hit the mark at 90% quads, but you've left some on the table in those other tissue groups, then like I'm still confident that maybe that person won't be like great at moving, but I know they're going to be fairly safe, in a closed environment. So I'm still able to like now do both. And so like, my advice is if you're new to this or you're early into this, like just err on the side of just like focusing solely on quads and everything else as like an afterthought until you get data that suggests otherwise.
Yeah, definitely. And that's something I've really learned to appreciate this past year, because I've rehabbed a very high volume of quad tendon grafts specifically. And the inhibition you get following that thing is absolutely gnarly. You really have to your point, blow it up with volume. And I mean,
I hope there's some surgeons listening to that, because I don't think that's trickled back to them yet. It's still the newest, latest, and greatest thing that's popping out, but like, man, that thing is tough, right? Like it's just a battle.
Yeah, it is. And it's even more difficult when, to our point we mentioned earlier, when they wait 2 or 3 weeks to come see you. If they haven't fired their quad in 2 weeks after a quad tendon graft, we're fighting an uphill battle for at least 10 months. It sets you back. But we've been down here, we've been doing a lot of high volume work for people to fight that. And to your point, this is not your stereotypical bodybuilding, like 50% chest, 50% tries. Like, we're doing probably 4 or 5 supersets, quad and quad, or 1 or 2 quad and hamstring, and the rest is all quad. And we're going to failure. We're doing some AMRAPs. We're doing a lot of BFR. Like, this is the amount of loading it takes to really negate that inhibition effect. And to your point that, training other muscle groups, I think if you do it right, you can actually get some of those other muscle groups while training the quad. If you want to bring calf in, just throw a heel float in. All of a sudden, you're going to light up the calf and you're still getting quad.
Right. Yep. Yeah, I totally agree. It's like, yeah, you sprinkle in 5% of the exercise into another muscle group, and like they're probably at that point like hitting 50-50 because they just want to use something else anyway. So yeah, I totally agree with that. You brought up like a really good point which I think we educate like our students on a lot, is like it's like everyone supersets here, like everyone, because you're on limited time, right? 45 minutes whilst is better than most places. It's still 45 minutes. If I was going to go strength train in a gym, like I'm going to spend an hour and a half doing that. Still not where we would love it to be. It's okay to go quad for your supersets. It's okay to just go quad for all 8 of your exercises. Like that's okay. You have to be smart about programming it in a sense of like changing your set rep schemes for what you're working on when you're challenging that quad. But it's certainly like you can't go quad ham, quad calf, quad ham. Like you're just that 50-50 is not enough. Like it's not going to get you where you need to go. So, I mean, you brought up a really good point with that. Like supersetting quads with quads is a
Yeah,
giant tick.
yeah, definitely. And to that point too, I think it's knowing when to superset versus when not to. And it comes back to what you want to elicit at the end of the day. If you want to load someone super, super heavy and get into like 5 rep max type territory, then you probably shouldn't superset that with another quad ISO or a quad burner type of exercise if your goal is, strengthening and that sort of thing. How do you go about kind of knowing when to superset versus when to just leave one exercise alone?
Well, I'd say like just based up on parameters, like in context for the way that we treat people, like we superset everything because we're trying to get as much volume into the session as possible. If there, but to your point, if I was to do something, let's say we're going like, like a 5x5 on something pretty heavy on quads, then that would be the time I might superset with something that's like not quad related, right? Because I want them to give me maximal effort on each set. But as soon as I'm done with that, right, then it's like volume quad for the rest of it, and I would change the movement pattern. So I would go like something that's like you could go quad closed chain, quad open chain, and that be your superset, if that makes sense.
Yep.
Or you could go like more like shallow depth closed chain into like deep depth closed chain, and that be your superset, and the shallow depth be like heavier load, and then the deeper depth be minimal to moderate load. And so you're challenging like the movement or like the comfortability of someone's like control of their knee at different angles, and so like that's where you're picking your quad supersets from. So I think those are probably like the biggest two concepts. I try to, like, if I have an athlete that's pretty self-sufficient or has some like experience in the weight room, like if I'm having them do that like first example where they're working on something that's like pretty heavy and needs a lot of rest break, like that's someone, especially if it's bilateral, like that's someone I'm just going to have try to like get that done like 15 minutes before we start my session. So like now I've already got some fatigue on that quad, and then I've got 45 minutes to like utilize the time to do everything else in there, where I really need to like watch and make sure knee goes in the right position, trunks in the right position, and we're getting good quad stimulus there. So sometimes that like heavier, greater effort type stuff should have less emphasis on quality, right? Because you just can't kill both those birds with one stone. And so for that reason, I would say if you're a fairly competent lifter, like try to get that done before you start the session with me, because you're going to do a pretty good job of fatiguing that tissue, and then I'm just going to like overload it.
Yeah, no, I like that. I like that approach. And I think you bring up a great point with that. Patients can do things before your session to make your session more effective, or patients can do things outside of the clinic to help their progress along. And you mentioned this before, as you program a lot of the hip strengthening for home by the sounds. What kind of other considerations do you throw into the home exercise program for patients in this stage?
Yeah, so this is actually really clearly outlined in our course. We felt like that was a huge part where that was neglected too. Like it just, you have to be doing something every single day for it to go at the rate at which you want it to. And so we have two different split programs. So we have a split program for someone that comes like 3 or 4 times a week in the course, and then we have a split program that come for people that come twice a week. And so that changes within the sessions that they're doing at home. Like what are they going to do, like a quad day, a hand, like an everything else day, and like and then another quad day, or are they going to do like everything in one day but just manipulate the percentages? So we typically run like a 2-day split type model, and that's what we present in the course. And there's a PDF like with an Excel spreadsheet in there with examples of exactly like the type of session that we do. So you can either like grab that and use that exactly for a period of time, or you can grab that and use the concepts from it in terms of percentages, because you'll be able to easily see if it's like a quad loaded activity or a posterior chain or frontal plane activity. Like it's really easy to follow along with that. But basically, if you're doing a 2 day a week in-person session, then you have a 2 day split homework program, and so you repeat that twice. So it's 4 days of strength training on your own, but only 2 different workouts. And so if you're doing that 3 or 4 times in person, then that 2 day split just becomes a repeat of like 1 time a week each, or 1 repeat each. And so now we're looking at like everyone is training 6 days a week, if that makes sense, if you do the math on those programs. But nothing, you don't need to get like crazy complex or complicated with this stuff, because remember, you're giving it to somebody outside of here. You need to like make it and cut it as simply as possible. And that's about as basic as a strength training program as there is. I like the repeatability of like doing the 2 day a week twice, because they just get more practice at the same exercises, as long as they're doing a good job. And obviously, like for one of the sessions, we'll take them through one set of each one of those exercises, film every single one of them, comment on what they're doing during that exercise, so they know when they go home and they like go to do a rear foot elevated split squat in the gym, they could just pull that exercise up on our app and see what they're doing, and make sure they're doing it in the right way. But the simplicity and repeatability of that, I think, helps them focus on like the progressive overload rather than like complicating the entire program. And so that's why it's so simple and basic.
Yeah, no, definitely. And, to that point about training 6 days a week, that's the frequency that it takes to really get adaptation here. I think a lot of people, and I'm included in this, we come from like a training background or a strength and conditioning background where we can crush something once or twice a week and see huge gains. But in this type of demographic, it's very different, and we need that high frequency. And I think you made this comment in our first podcast that there's a frequency element, but the intensity also kind of roller coasters too, right? Like you're not giving people, your super heavy sets at home to hit in the gym on their own. You're doing that in PT twice a week or 3 times a week. It's not super heavy every day, but we have to keep the quad alive every single day.
Yeah, the inhibition piece to ACL rehab is the main kicker on this, in that like just the frequency of stimulation, like you said, every day is the most important. So like even early on, if that's just like your straight leg raise piece, right? Like that's so important to do that multiple times a day, every single day. We give a really beautiful outline of that in the course too. So all of our homework programs are listed 5 times a day. And so we feel like turning that quad on early when it's at its worst 5 times a day is, super important. As you get into this middle stages that we're more talking about here, it's got to be stimulated once a day. You can't let it go a day without like challenging it. Now, it doesn't need to be like having difficulty sitting on the toilet type soreness every single day from that, but it does need to get like stimulated every single day. That's definitely important. It's not a healthy tissue yet, and it doesn't, like you said, respond from or in my opinion, doesn't respond from training 1 day a week. It just needs that frequency of adaptation.
Right, definitely. And I'll throw this in as like a curveball. I've had 1 or 2 patients where we go at it with that model and things start to get a little bit pissed off. Knee starts to get a little bit puffy and things swell up a little bit. Where do you go when, we start loading real heavy and all of a sudden the tissue starts to get a little bit irritated?
Yeah, so if it's knee joint that's getting irritated, this is the one time the caveat is that you have to back off, because the number one thing that swelling and pain do in a joint and in the area is, inhibit the tissue around it, right? And so pushing through that is just not good. You're fighting an uphill battle. So that's the caveat of ensuring that if you're giving someone 6 days a week of training, that you're staying in touch with them and you're measuring knee circumference, right? Or you're just usually subjectively asking or doing like patella modes and checking knee swelling, because if that's lingering, I don't care how many like quad exercises you're doing, you're not getting the transfer or like the stress to the tissue that you want to then like turn over and produce like a better tissue. It's not happening. You're trying to fight an uphill battle and probably causing more swelling in the process too. So like swelling is that number one like contraindication that I have for like trying to do like progressive overload. Doesn't mean I'm not going to squeeze the tissue and like keep it active around there. I'm certainly not loading that thing when it's puffy and swollen. It's not getting anybody anywhere.
Yeah, no, definitely. And to that point on inhibition, I think that this is a place where some of those little things that a lot of people like to bash online, and maybe I'm guilty of that myself, your ice, your compression, your elevation, like those little things can make a huge difference here. There was an individual I was working with not too long ago who his knee started to get a little bit puffy as we kind of got into some of the more advanced loading. And I told him to go home and just ice it twice a day and add in some compression boots. And we retested his quad 2 weeks later, and he went up 40 pounds in 2 weeks. I don't think I really loaded him enough in those 2 weeks to cause that much of a spike that quick. But you get that fluid out of there, and all of a sudden we can really engage the tissue a lot better. So I certainly like that point on assessing the edema and making sure that that gets factored into your programming. As far as the overall approach to loading, you've mentioned this a few times, like load the quad, load the quad, load the quad, but you know it as well as I do that there's not really one set like quad exercise. Like we could give someone a single leg squat and call it quad loading, but how they move through that pattern could be very hip dominant and they might get almost no quad load. So how do you go about changing the setup of your exercises to make sure that you're getting the stimulus that you want from it?
Yeah, I mean, setup is the most like key thing you just said there. So I would say like I've gotten so much more simplistic on the exercises like I pick for patients to do to load quads. Like I would say like 3 years ago, I had like a huge like volume of exercises that I would throw at people. And I feel like I've filtered a lot of those out based on how much cueing I have to do. Like my goal is to be able to do this, set the parameters up for the exercise so that it's almost close to impossible to avoid loading that quad. And if you're going on like the scale of things, the most impossible way to avoid quad would be a long arc quad or your single leg knee extension, right? It's impossible to avoid that. And then I basically just have a continuum like in my mind of exercises that I have that would fall like along there, like valuable, like on one side, tick, yes, like easily compensated with other tissues. No, okay, like that's going in my bucket of like 100% I'm trying to do this, right? Or highly valuable, but easily like manipulated and compensated for. I'm putting that further down the scale of like, do I want to do this with somebody today? Or highly valuable for quad, it's okay. And really easily compensated away from quad. Like I just throw those things out now. I just don't think they're as valuable anymore. So that's the way I look at it in terms of like what some of those exercises are. Again, like we talk about those extensively like in this course coming up too. So there's some really great like big bucket exercises that you can pick up from that if you guys are interested in looking into it. And that was our goal, is to like simplify this like middle process, right? Like just so many options out there now. When I first came out, it was like you couldn't find any information on like different variations of how to load the quad. And now it's like if you put that in like your Discover page on Instagram, you're gonna have like a billion different quad exercises, and half of them are gonna be for like your glute or your hamstrings. It's like hard to filter out information now. So we really took a good stab at doing that in the course. I really like manipulating if it's a closed chain exercise, because those are the ones that you're going to invite more compensation for. I think first it's got to be predominantly in the sagittal plane, right? Like that's your first check, because that's really like how your quad functions for the most part. Secondarily, I'm either like constraining or manipulating the trunk, right? Or we're manipulating or constraining or giving a target or cue to the knee position or the tibia position. So that would be like your classic like knees over toes, or how far your tibia like translates forward, or how far it doesn't based on like their tolerance. So those are two big factors: a nice vertical trunk and an extremely forward knee is going to yield the most quad load. And then you just regress back from there based on what somebody can tolerate. If you ask me what's more important, like earlier on, I would say throw the load, like the external loads, out the window and focus more on that trunk position and that knee position. Get somebody comfortable moving through that like pattern really frequently at lower loads, and then load it up. Don't back or regress off your positional stuff, like your constraints or your vertical trunk and your knee forward. Don't back away from those, but add tons of load early on, because I think there's something to be said to overemphasizing or encouraging the movement pattern of that quad loading early on, and getting a lot of reps to that earlier on, rather than encouraging something that is not as stimulating to that tissue or might invite more or more compensation. But because of the external load, you're still getting equal quad stim. Does that make sense?
Yeah, it does. It does. I like that point on external load. And that's another piece that I feel gets missed a lot is, if I have someone do it body weight only, or I give them, say, 20-pound kettlebells or dumbbells, 40-pound dumbbells or kettlebells, like understanding what effect that's going to have on the quad or, whatever tissue I'm trying to load, and taking it a step further, say I look at the weight that they're using and the exercise they're doing, I can then manipulate set rep or ISO hold time, because at least from my eyes, I do a ton of ISOs with the people I work with. So understanding the effect of that external load, the external cue, and then the type of rep range or the type of load that you're duration of hold that you're putting that individual through. If you can really master all of that, I think that you're going to effectively load. It sounds like a lot to consider and a lot to think about, but I think it's really a lot more simple.
It's two things. Like, it's that trunk position and that knee position.
Yeah.
If you get those down, then you can just work out from that framework. And this is for closed chain stuff. So I love like your idea about ISO holds as a place to start or a place to begin to challenge that position, because you're putting someone in the ideal position and then they're remaining there. So if they move from that position, right, big X, like they weren't able to maintain that posture, so they weren't able to maintain that load over the quad or whatever it was that you were challenging. And so now you just know, like, from here, I just need to like reduce weight or reduce the time or something like that. But your main point is that you're manipulating from a specific position, and by reducing the movement in and out of that position, you know that they're hitting what you're asking them to hit, right? You know that they're getting the stim in that one static posture as you want. And so, whilst you have to throw terms like ISO or like trunk position or like tibial translation or like different planes of motion, they can sound quite confusing. When you look at the actual exercise that's being produced, it's like a single leg wall slide hold. Like, how more simple can that be? Like, it's very easy. That's something that everybody can do in their clinic. It's also something very easy that you can ask your patient to do at home and set up the parameters so simply. But that's all we mean by like vertical trunk position, is like there's a wall in your way that's stopping you from not doing a vertical trunk position, or there's a target in front of your knee, like a box that I'm asking you to touch to. Like, these sound complex when you talk about it in this environment. When you look at the exercises, or you finally understand, like, you just need a vertical thing to stop moving, or you just need a target to go to. They're quite simple. They're quite easy in concept. And when you move away from them, you just invite more complexity to like cueing. And that's when it gets like more challenging or more troublesome, right? Like, you're constantly have to like watch or have a hawk eye, or like put a hand here or touch a band there, or like tell them to do this, or, rotate here, or like shift here. And then once you start doing that, you always get to the end of the sequence of the exercise. You're like, crap, I just wasted like 20 minutes of my time yelling at this patient, not getting what I wanted to out of them.
Yeah, no, definitely. And it's one of those things too, if you have to put that much effort into one exercise or one movement, are they really ready to progress to that level?
No, yeah, simple answer.
So
wasn't sure if that was rhetorical.
Tim, I feel like we've discussed a lot of different considerations as it goes into programming for the ACL. And, you've mentioned this course a few times there for people who want to learn more and learn from you about how they can program more effectively and efficiently for their patients recovering from ACL injuries. Where can they find that at?
Yeah, so if you go on our main website, which is truesportsphysicaltherapy.com, there is like a little tab at the box. It's like titled Education or branded as True Sports University. So if you Google that too, it'll come up. And on there, we just launched that first course. It's called the ACL Masterclass. Basically, it is a course that will help guide you through day one all the way through to 9 to 12 months of rehab. So it's basically what we call like a video protocol form of ACL rehab. It's super simple. Like you could take it if you're still a student in grad school, if you want to just be more ready to do this when you get on your clinicals, or if you're a newbie, like you're a rookie out in your first job and you just want to accelerate the manner in which you want to treat these things. Or you might be a vet and like you're in an outpatient private practice and you don't see these all the time, right? And instead of like stressing, worrying, going home, researching and studying all the time, you could just lean on the fact that we have a ton of clinicians that have put a lot of work into this course and have really simplified that process. So in week one, go to the videos in week one, follow along with those, check those boxes. At week 12, go to the week 12 videos, follow those videos, and you can sort of like just plug and play along that entire process. So True Sports University, you can find it on our website. We're running a special on it, I think, right now. So it's $250 off. It is 7.5 hours of continuing education credits, and it is certified in, I think, every state except for Maryland. We're about 1 week away, I think, from being accepted into that, which we're almost a guarantee for. But if you're in Maryland and you want to take it, purchase it, take it. We'll give you a certificate once the CEUs come through. If for some terrible reason they don't come through, you just get in my DMs and we'll just refund you for the course as well. But that should be there in a month. So jump on the website, or if you want to follow me as well on Instagram, dr.stone.dpt. We're always posting links and things like that to it. So you can find it in those places.
No Lax Doctor handle anymore, Tim?
No, I passed on the baton to Austin at Lax Rehab. He's working with much more interesting lacrosse players that are a lot better than any of the lacrosse players that I work with. So if you want keen, like really good lacrosse-based rehab, he's your guy to kind of go to and look there. I'm in the shadows of him now. He's killing it.
That's awesome. We'll link to all of that in the description below as well. So if you didn't quite catch those, you can just look there. Tim, it's always a pleasure talking with you, man. Really appreciate your time and everything you're doing.
Dan, you too. I think there's, not a ton of people that spend like time putting information out like this for free to the PT world. And I think, if we don't have people like you who are looking for people to help like share their information, I think we're in a much worse place. So definitely appreciate everything you do and appreciate everything that you do for my Seagulls down in Salisbury too. So thanks for having me on again.
Thank you so much for listening to this episode of the Brawn Body Health and Fitness Podcast. If you liked this episode, please make sure to share it with a friend, subscribe so you don't miss any of our upcoming episodes, and leave a review. This way we can spread knowledge and motivation and help reach more people. Thank you again for listening, and I'll see you next time.